Good morning, everyone, and thank you for that wonderful introduction. I have to make a correction. I certainly haven't reached that illustrious stage of being a professor yet, but I'm very grateful to be with you. And then just to say that many of those opportunities to speak to the public are really afforded by the institution that I work for and the institution's reputation and stature within the broader context of South African outbreak preparedness, alert and response, and particularly so for communicable diseases. So it's my pleasure today to be sharing with you some reflections on the topic of preparing for epidemics in South Africa. I want to share my screen so that we can share together an outline of the presentation. And I just want to check that everyone can in fact see.
Yes, we can see it.
Great. Okay. So this morning I'm going to take us through some reflections on the public health events or emergencies that I've been involved in. These include the Life crisis, not the crisis itself, but more the government response to the crisis. Secondly, the listeriosis outbreak, and then lastly, the current pandemic that we are in at the moment. And then ask ourselves, and indeed all along as I narrate really anecdotes and reflections, ask ourselves what we have learned. So the Life crisis began in the early teens of the 2000s. Essentially, what happened was that there was a global move of policy to support community management of persons with mental health disabilities who are referred to in the South African legislation as mental health care users. The Life group had cared for mental health patients, certainly in Gauteng, since the 1960s. And in a rather precipitous and poorly thought through event, mental health care users from the Life Institute were moved across Gauteng to certain NGOs to facilitate their deinstitutionalization. The National Department of Health then asked the NICD to get involved to coordinate the relocation of these patients back to Life essentially, this happened after the Health Ombudsman was requested to investigate the crisis and came up with a recommendation that within a period of 2 months that the mental health care users were, the government was required to move the mental health care users back to a place of safety. And so within a period of 3 months, we relocated 751 mental health care users and accounted for the whereabouts of the remaining patients. In order to support this relocation, we used the incident management system that we had been taught by the WHO Emergency Response Framework document. This document emerged from the West African Ebola crisis, which played out over 2013 to 2014, and taught the global community a big lesson, and that was that without good coordinating mechanisms, outbreak response fares poorly. People, resources are misused or poorly allocated, and coordinated attempts become very hard, if not impossible. And this document outlines what's called the incident management system, which was a system adopted by a number of key thinkers in the WHO from pre-existing disaster management response systems in their experience. Essentially, the incident management system requires an overall structure with team leads in particular areas, along with an incident management plan that is carefully guided by an overall aim and then aims within the different substructures. So when we were asked to support the relocation of patients, we collectively with the appropriate experts drew up a plan, the aim of which was to stabilize and restore the health and dignity of mental health care users affected by the Life Sitimeni relocations. And we established an operational structure that you see below. The operational structure had different teams. The district teams in the districts of Gauteng were monitoring the users in situ in their current place in the NGO while we were preparing for relocation. The family liaison and communications team included social workers and family representatives to communicate and keep family members abreast of what the developments were. A logistics team provided the transport and emergency medical services and a 24-hour helpline for family members. A field team comprising social workers, psychiatrists, psychologists, mental health care users, and occupational therapists did the assessment of patients prior to relocation, identified their particular needs, and saw to it that these were met before, during, and after the transfer. A data management team collated data from all the sources to establish and monitor the whereabouts of the users so that family members could know exactly where they were, as could the health authorities. And most importantly, the inspections and specifications team did the initial preparatory work to create a legal framework to support the re-establishment of the Life Sitimeni facilities that had been mothballed. So this is what we did. The bars represent a number of mental health care users from the different NGOs, and the x-axis represents the date in March and April of 2017. It was an immense undertaking. Many mental health care users did not even know their names. And so the finding of their records, the ensuring that they had adequate medications during the transfer, ensuring that their family members were informed was a key operation. And so we learned a number of lessons. Critically, we learned that in the incident management structure, that's an area that we had neglected from an operational perspective, thinking that, oh, it will all happen, was perhaps one of the more critical longer-term interventions that, or longer-term areas that would cause us trouble later on, and hence needed support in the moment, was finance and procurement and human resources. We had to engage with a lot of external contractors. We had to procure services and procure resources to support the relocations. And because of the need to follow correct procedures, it was critical to have people in the know to do this. We also had to have a rapid development of a data management system. And of course, the situation changed frequently, and that often meant that decisions needed to be revisited when new information became available. We also realized that people did not have insight into how the incident management system functioned, and it would have been helpful had we a core of trained persons in the incident management system. We also learned communication is key. Emergencies are high profile with lots at stake, and it is absolutely essential to keep all role players from the highest figureheads to the drivers in the team, so that everyone knew where we were going and what we were doing. The next outbreak or public health event that I was involved in was the listeriosis outbreak. And essentially what happened here was that through complete oversight of the production factory, the brine cooling tanks in which the polony specimens were cooled after production, after cooking, became contaminated with Listeria monocytogenes, which is a bacteria that thrives in saline solution and in the cold. And the, of course, the polony by the manufacturer in question had a national and in fact even a continental distribution. And because the inside meat and the outside casings of the polonies were contaminated with Listeria, there was and became a South African national contamination, not only of the brand's polony, but also the other polonies that were stored on the same shelves. And this led to over 1,064 known or identified cases with 27% mortality. what happened and how we were able to identify the source was that early on, through the implementation of molecular whole genome sequencing of the Listeria pathogens, we identified that they were all of the same sequence type, indicating that this was a point source outbreak and likely a contamination of a particular facility. We developed a strategy in the beginning to identify the source, which included clinical vigilance for gastroenteritis, febrile gastroenteritis, which is one of the clinical presentations of listeriosis that has a very short incubation period. And we hoped to then identify particular foodstuffs that people had consumed, people who had been diagnosed with listeriosis. We also then wanted to culture food in these patients' fridges, and then obtain food and environmental samples from retailers and food processing plants in order to identify the particular factory that was involved. We did establish through interviews that persons who had eaten polony had a 21 times greater risk of developing outbreak associated listeriosis than persons who had consumed, or at least than persons who had listeriosis due to a non-outbreak strain. On the 13th of January 2017, we identified a cluster of 10 cases of febrile gastroenteritis in a creche in Soweto, and we raided the fridge of the creche and cultured listeria that happened to have the outbreak strain. And that led us to the affected factory, and it turned out that 1/3 of the 300 swabs collected had listeria as a contaminating source, or at least a contaminant in the environment, and 26 of those were the outbreak strain. So soon after the source of the outbreak was identified, the Department of Health asked us to activate the Emergency Operations Center in order to coordinate a multi-sectoral response to the outbreak. And similar to the organogram that you saw for the life crisis, we created a similar structure for the coordination of the response to the listeriosis outbreak. Essentially, we had a group that was responsible for each of the various areas, and we had a project plan. The aim of the project plan was to control and end the outbreak, but also to strengthen systems to prevent future listeriosis outbreaks. The different areas of the plan each had their own aim and objective. The epidemiology and surveillance track had the responsibility of monitoring new cases, generating epidemiology curves, providing situation reports to detail the state of the outbreak, and you see one of the outputs there. This division also collected clinical and environmental isolates and conducted whole genome sequencing, allowing us to track the progress of the outbreak strain as we detected clinical and environmental cases. This unit also was responsible for collating the food history interviews, developing a database to support ongoing surveillance going forward, and developing international ties with colleagues to strengthen our own surveillance networks and integrate us into InfoSan, the World Health Authority organization responsible for food safety. The environmental health and training track had the task of identifying all the processed meat production facilities in South Africa, developing material to support factory assessment, including a risk assessment tool, a factory inspection checklist, and revising the and representing again in the form of training activities the duties and obligations of inspectors, and providing insight into the legislative framework. We then trained and conducted training in all provinces of South Africa, and together with these trained teams and a core team based at the NICD, we inspected and tested all 157 processed meat facilities in South Africa. We were supported by the laboratory, the environmental and food testing laboratory of the NICD, the Infection Control Laboratory at Charlotte, okay, and this unit conducted, or at least refined the laboratory tests and procedures for the detection of listeria from environmental swabs, and developed food collection and monitoring and testing standard operating procedures, and then also supported the courier and transport arrangements of the specimens in order to get them to the laboratory within a certain time. Critically important was risk communications and community engagement. And these teams across the country, the existing RCCE teams within the provinces, conducted training on food safety, conducted community engagement and outreach activities, distributed posters and materials in 11 official languages, and maintained a social media presence in order to support the improvement of public and consumer awareness of food safety. Very importantly, the legislative and policy environment team spearheaded a number of changes in the legislative environment around food control. In fact, the food legislation did not include listeria as a foodborne illness, as the legislation had been passed prior to the 1990s, when it was realized that listeriosis was transmitted through contaminated food. So what were the learning lessons? Essentially, outbreak response is a multi-sectoral endeavor and requires coordination, communication, and planning. We learned that prevention is key, and an up-to-date policy environment supports prevention. We also at the NICD had not conducted surveillance for listeriosis during the years prior to this, although we did have access to listeriosis blood culture results from the National Health Laboratory Service. And it was a key development that we now included formally listeriosis as a disease under surveillance. But not only that, that we also implemented routine molecular genotyping of the virus, of bacteria, in order to support the early detection of clusters of cases rather than wait until epidemiological signals were received. We also learned that public cooperation with health interventions is critical, and that up-to-date and flexible legislation supporting surveillance and public health measures . Apologies for that, I had a bad dog in the house. So one of the key things was that the National Notifiable Medical Regulations also did not have listeriosis as a disease under surveillance. Again, because this legislation had not been updated since the 1970s. And so as the outbreak emerged in December 2017, an updated list was provided, and the which included listeria. The other advancement that the legislation made was it gave the minister power to declare any pathogen a notifiable medical condition, or any condition a notifiable medical condition that would have that would allow the minister the powers to enforce the regulations for any new condition should a new condition emerge. So the next outbreak is one that we're very familiar with, and that is the present one, COVID-19. This was a statement by our Minister of Health, right in February last year. South Africa can cope with COVID-19. You may have your own opinion as to whether we can or can't, but I think we've done particularly well. I want to support reflections in 4 key areas, and that is the coordinating structures at national level, data management and analysis, provincial level responses, and again, risk communication and community engagement. So, of course, the virus was imported from Europe and was followed by the rapid promulgation of legislation to support lockdown. And you can see in the graph in the top right that shows the epidemic curve and the trajectory of the curve until the date of the lockdown, which was 27th of March 2020. And you can see how the cases that occurred after the lockdown were really cases that occurred within the incubation period, at least the initial cases within the incubation period following the cessation of international travel. It became clear early on that the coordinating structures that existed in the Department of Health and more broadly were inadequate to meet the demands of the outbreak. What had happened was, in the weeks prior to the WHO declaring coronavirus a public health emergency of international concern, the Minister of Health had asked the NICD to activate our Emergency Operations Centre. And we set up, as we had done for the Epidemiology and the listeriosis crisis, an incident management team with an organic structure, as you see there, with different teams of people responsible for different activities. We also worked in conjunction with, obviously, the National Health Council, which was responsible for the contractual agreements of the provincial health departments with the national department. And the first few weeks really showed not only to us, but also to the broader Department of Health, that our structures and our reach at the NICD were really too small to accommodate for the scope of events and decisions that needed to be made. And so our president created a National Command Council very early on, in which essentially cabinet members were party to and made key decisions around lockdown and the conditions for that. What also happened was that the minister appointed a ministerial advisory committee, who then created subcommittees related to public health modelling and laboratory services. And the NICD slotted into the incident management team, which was then taken over by the National Department of Health. Essentially, what this did was broaden the reach of government to create an environment conducive to multi-sectoral coordination at a very high level. And also supported and increased the depth of experts who were able to advise the government, and not only the health department, but every single other department who had requests and inquiries related to the implications of COVID for their particular area of responsibility. A further layer of management in the department was added, called the Project Management Office, and this was supported initially by the private sector to help coordinate the financial and human resources components of the COVID response, which became enormous and still is to this day. So this slide really summarizes what I have shared with you. I haven't mentioned the NAT joints, or NATJOC, the National Joint Operations Committee, which is essentially a security structure that predated the entire operation, which is responsible for addressing security threats of any kind, be it environmental, such as drought, or political, such as stability on our borders. And this NAT joints was in effect the operating, or the actioning agent of the National Command Council. So decisions that were made by the National Command Council were then brought into effect by NAT joints. And so we, as the incident management team of the Department of Health, had a seat on NATJOCs and kept NATJOCs informed of certainly the health interventions that were taking place. So looking at the next level, which of reflection, which is really the data management and analysis. So there were the burning question, of course, early on in the outbreak was how to track the epidemic. We used cases, admissions, or reported deaths, or excess deaths. The problem was that with regard to laboratory testing, although there were very much fewer laboratory testing groups in the country compared with globally, other countries have many, many private laboratories. We really only had 3. There was no data sharing of laboratory results between the private labs and the NICD. When it came to admissions, there was no system for tracking admissions in the public sector that could give us the data of the number of admissions on tap. And certainly with regard to deaths, there were 2 problems. The first is around training of healthcare practitioners in how to complete the death certificate, particularly the cause of death. And secondly, there has been a long-standing delay in capturing the cause of death, related really to the fact that the Department of Home Affairs receives the death certificate with the sealed section pertaining to the cause of death. The logging of the actual death itself is quick and efficient, but these paper forms are then transported to Stats SA, where they are captured manually, and usually our cause of death reporting lags by a year or more. And so this system was certainly not conducive to us understanding the cause of death and the number of deaths due to COVID. So what emerged, and really I'm telling you the final result, it's certainly by no means how it all happened, was that a data interface, an automated data interface, was progressively established between all the private labs and all the newly developed labs under the mandate of the Notifiable Medical Conditions regulations. Fortunately, the NMC regulations had this clause that allowed the minister to declare any particular or novel pathogen to be a condition under falling under these notifiable medical regulations. And so it was this clause that allowed us to have access to the data. And so this data source is the source of the very excellent surveillance reports that you'll find on the NICD that are issued weekly and are in the public domain. The second intervention that happened was that the NICD set up a system called DAT-COVID, which was a portal for logging admissions of COVID patients. Essentially, any patient who was diagnosed with COVID was logged by the admitting hospital and then had three particular time points: a date of admission, a progress report, and then a date of discharge or death, along with parallel information around their condition. There was a particularly difficulty in coordinating the rollout of DAT-COVID. There were a number of other competing systems, and there was indecision by key role players around which system to implement. Finally, the Minister of Health issued a directive requesting compulsory reporting of admissions, both public and private sector, to the DAT-COVID system. And so today you can find the reports, the weekly reports on hospital admissions, also on the NICD website. When it came to deaths, this was an intractable problem in terms of the ability to understand cause of death due to COVID. The existing systems come in through two sources: the DAT-COVID deaths amongst hospitalized patients, and then the community deaths that have tested positive for COVID. And this followed a directive from the DG of Health to conduct post-mortem COVID testing on all community deaths. Perhaps the most useful data, however, remains the excess deaths report that is issued by the Medical Research Council to support interpretation of death data. Of course, one of the limitations of this is that the death data, the cause of death amongst those excess deaths remains uncertain. If we look at the provincial level responses, I was lucky enough to, in the earlier part of the outbreak, to be seconded initially to the Western Cape, and then secondly, initially to the Eastern Cape, and secondly to the Western Cape, and obtain some key insights into the challenges that were faced really by provinces who are the service delivery hub of health. Essentially, the outbreak progressed at different levels across different provinces, and some work by Stefano Tempia calculated the R0 for different provinces and really showed that Gauteng and the Western Cape had the highest R0, indicating probably a function of the localization of the imported cases initially to these urban centers. But when we did a deep dive, essentially what was happening was that the outbreaks in the provinces commenced in the urban areas, and there were invariably a number of super spreader events. So a key one, for example, in the Eastern Cape was an outbreak at the Correctional Services Facility in East London, followed by an outbreak where a very prominent GP developed COVID and had over 140 contacts. And this led to seeding of vulnerable areas and with consequent transmission. The Western Cape had initially a very robust contact tracing system, but it was completely overwhelmed. One of the challenges they faced was limited adherence to lockdown in the poorer socioeconomic areas where this was really not possible, together with cluster outbreaks in essential services that seeded the outbreak into the poorer socioeconomic communities and created hotspots. One of the challenges in the Eastern Cape, and indeed everywhere, was the length of time it took from the identification of a positive case to the interview of contacts and the testing results of contacts being available. This could have, at times, was ranged up to about 14 days. And of course, with the incubation period and the serial interval being between 3 to 5 and up to 5 to 7 days, it was really not possible to contain the outbreak using contact tracing when the turnaround times were so slow. Compounding this was the fact that the laboratory services were slow to take off, not through any fault of their own, but really through international reagent supply problems. And enormous backlogs were generated in the laboratory that further compounded not only the ability to contact trace, but also to diagnose patients who were admitted with suspected COVID. And this led to immense pressure in the patient under investigation wards and may indeed have contributed to limitations in healthcare services to manage the situation. So the Western Cape took the lead in limiting the criteria for testing, and this unfortunately adversely affected the epidemic curve. So it looked as if in the first outbreak, the Western Cape had a smaller outbreak in the first wave than in subsequent waves. Essentially, some of the problems faced by the provinces were delayed readiness of quarantine and isolation facilities, difficulty in social distancing, difficulty in contact tracing, issues around supply chain management of PPE and laboratory testing backlog. The next area that I briefly wish to focus on is the issue of risk communication and community engagement. So we had learned in the past, those who were specialists in communications, that RCC activities are key in supporting public trust in authority structures and in engendering cooperation with public health interventions. The very difficult and not unique problem created by COVID was that there were key uncertainties among scientists in the effectiveness of public health interventions. And this tension of uncertainty created gaps for misinformation. And indeed, the WHO coined the term an infodemic and has subsequently generated a whole field of research around how to communicate and manage uncertainty in South Africa. So not in South Africa, globally. I did a brief survey amongst 8 leaders in COVID responses, both at national and provincial level. And if you just look at the heat map there, you can see that where the figure is minus, individuals developed increasing uncertainty across a 6-month period with regard to certain key health interventions. So essentially, this graph, this heat map represents a before and after. So I asked the question, how uncertain were you in March and how uncertain are you in October? And a negative score reflects an increasing level of uncertainty. Certainty, the red area. So the point is that people were, even the experts were uncertain around the efficacy of certain interventions. All this did really for us in the outbreak space was to renew our efforts and our appreciation of the importance of clear communications. And you'll see on the website that, certainly the NICD website and the government website, the SA coronavirus website, that there is renewed emphasis and a concerted effort to ensure that communications are clear. So what are the lessons learned? Well, very importantly, public trust in health authorities aids in dispelling misinformation. And at no time is this more important than the need for the vaccination. There is so much misinformation around vaccination, and the trust that the vaccination is actually going to benefit individuals is key to the uptake. Very importantly, coordinating structures and training needs to be replicated at a provincial and district level. In our country, invariably with mass outbreaks like this, the provinces and the districts are the service delivery points, and the coordination across the different is key. We learned that legislation to support public health interventions is important, and of course we've all seen the disaster management regulations being promulgated, and the notifiable medical regulations will be changed to incorporate some of those key recommendations in time to come. With regard to surveillance, the molecular epidemiology and the molecular sequence typing has proven invaluable in our early detection of variants of SARS-CoV-2, and it is an essential component of outbreak investigation. We've also learned the importance of data management to support real-time collection, analysis, and sharing of quality, meaningful data. So I was quoted by the Government Communication Services early on in the outbreak when I was trying to put a positive spin on what was for all of us a very frightening time in the country. We didn't know the impact of COVID. We didn't know the immense social and economic costs that would ensue. But the reality is that every outbreak leaves a legacy that allows us to harness the good or the gift that there is in that outbreak in terms of the way we organize ourselves as people, and more importantly, the way we look after and care for ourselves as a community. Looking back, in life as said many, the key fault, perhaps apart from the lack of quality standards for the NGOs, was really the communication with families and the listening to the people. There were multiple opportunities the health authorities had in the life said many crisis to correct the mistakes that they had made, but they were not open to listening. And so one of the things that we were sure to include, and not because we were clever, but because it was self-evident that this was a problem, was the involvement of community and family representatives in the structures responding to the outbreak. In the listeriosis outbreak, we learned about the importance of molecular epidemiology, particularly in relation to listeriosis, but this has become pertinent even now in the SARS-CoV-2 outbreak management, and there is no respectable public health institution in the world that would not want to or has already included regular molecular genomics as part of an integrated response to outbreak management. We also learned in listeriosis that it is absolutely critical to coordinate across sectors. So the interesting thing about listeria was that it involved a number of sectors. So it was animal health and human health and environmental health, and then also in terms of legislation, the Department of Trade and Industry. And classically and traditionally, we work in silos, and we don't necessarily think about what our colleagues in the animal health industry or in the Department of Trade and Industry are doing. And when it comes to outbreaks, it's absolutely critical to be able to have structures that allow coordination across the sectors. When it comes to COVID, we have certainly learned the importance of real-time quality data and data management systems. We've learned about messaging to the public. We've learned about maintaining public trust in authorities. And so really, if we look back, what are the broad principles that we can take with us into this discussion over the next 2 days? Firstly, there is the recognition, essentially, that outbreaks indicate that something underlying is wrong or inadequate in the way our society is structured, and it is a signal that we need to do something to correct that. So whilst some people have said, well, SARS-CoV, the COVID pandemic, it's a virus, it's more than a virus. It is what people and authorities have called a syndemic. It is a conflation of social weaknesses together with a virus that has exploited the gaps in our society, such that those who are more weak and vulnerable and have less access to resources suffer an unfair distribution of illness and disease. Secondly, a broad principle is that response to outbreaks cannot be done by a given single institution. It requires a multi-sectoral coordinated response, and that these structures need to be part and parcel of our outbreak preparedness. We can't just suddenly come together when there's a crisis. We need to know who our colleagues are, and we need to know what the structures are in order to work well. The last broad principle is that health emergencies are not just related to communicable diseases. Health emergencies are such because of the health consequences of an event. So the health consequences of a drought, or the health consequences of a cyclone, or the health consequences of a policy decision are the substance or the structure of what makes a public health emergency, something to pay attention to. And because of that, it is necessary to adopt an all hazards approach to the preparation for emergencies. So what are the key areas that I think we need to take from our South African experience in outbreak investigation management, and perhaps more broadly speaking, health events? The key areas are that firstly, we need to continue with policy making to further refine and define the legislative environment in which emergency response takes place. There are no defined structures within our current legislation that allow us to come together and to coordinate an outbreak response. And what this leads to is that at the beginning of an outbreak, there's a lot of jostling around who's going to take the lead. How are we going to do this? Which department is going to take the lead to coordinate this response? How are we going to do it? And this wastes an incredible amount of time and also creates an incredible amount of uncertainty and friction within institutions and across institutions. The second key area that I believe is critical is that we need to invest in data management infrastructure. Certainly at the NICD, this is perhaps one of our weakest areas. We need to have preemptive data sharing agreements. We need to include laboratory testing and clinical information. And we need to go beyond this to include not only health-related data, but also environmental health-related data and economic data and social data. We need to be able to have a way to coordinate the collection of data so that it can be interpreted holistically and not just as a health outcome. The last area is that we need to have human resources to support this data management infrastructure. And unfortunately, these are not cheap and they're not easy to come by. We need to have not only the hardware structures, which are relatively easy to purchase and set up the data warehouses, but we need to have the analysts, we need to have the EDL specialists, ETL specialists, we need to have the people who have insight into data warehousing so that we can set up structures before the outbreak in order to support outbreak response. Lastly, and not least, we need to invest in training on and preparations for communication. So we need to have communications plans. We need to ensure that our public health leaders are trained in the communication of uncertainty so that when it comes to engendering public trust, we have a cadre and a core of people who can take the public with them. So I think that's really all that I have to share. I'm very grateful to the NSTF for actually convening this subject. We have globally been involved in South Africa as a South African contributor to the Global Outbreak Alert and Response Network. And we have been having outbreak investigation and planning sessions forever, but these events have never attracted the level of public interest that is necessary to support broad scale and multi-sectoral support for outbreak interventions. So really, I believe this session comes at a good time for our country, and I'm very looking forward to the contributions that come from yourselves going forward. Thank you.